Okay, so let's start the presentation. The topic I'll be covering today is the neuroanatomy of the cavernous sinus. I thank Dr. Chirag for giving me this opportunity to explain the details. So this section, this topic is 6 things. So initially we'll discuss about the definition of cavernous sinus. Then we'll discuss about the walls of cavernous sinus, the neural, arterial, venous relationships of cavernous sinus, the anterior clinoid process details, and the anatomy of the carotid column. So let's go into the cavernous sinus basics. So here we'll talk about what we already know about cavernous sinus from our knowledge, what we have gained during our MBBS, and we'll go into the detailed neuroanatomy of it on the due course. So cavernous sinus is defined as a dural envelope through which the cavernous ICA courses. So it has many major important artery, vein, and cranial nerve coursing through it. So it's the importance of cavernous sinus neurosurgeon is that the most important artery of the brain, which is the internal carotid artery, courses through it, and many important cranial nerves course through it. So it becomes quite a very important area as far as neurosurgeon is concerned. So whenever we study neuroanatomy, we have to of an area, we have to initially understand the rough shape of the approximate shape of the area. So which will be defined by the walls of the area. So we'll initially discuss the walls of cavernous sinus, then the margins of cavernous sinus, the arterial venous relations, the nerves and gyri sulci related to it, and the ventricular relations. The reason I gave this slide is it is not quite related to cavernous sinus, but whenever you study anatomy of a region, it has to be classified into these headings. So say you're studying the anatomy of the ventricle or the frontal horn. So it has to be defined in these headings. Even in Roton textbook or Roton neuroanatomy, surgical anatomy, everything will be given in these headings. When you so it helps to organize the relations in certain shelves. When you read scans of pathological conditions, also you should try to define the scan in these details, so that even if you close your eyes and listen to the description of your scan, you should be able to picture. You should be able to picturize the lesion. So coming to the basic neuroanatomy, which we know from our MBBS. So this is a basic picture which we all would have studied during our MBBS. There are some incorrection, and it is not correct to the sense of cavernous sinus is something which is situated on the lateral aspect of the body of the sinus. So the body of the sinus is about the center we have the sitting over it. So the cavernous sinus is situated between the pituitary and the sphenoid sinus and the temporal lobe lateral. So in the small space, many important structures in the brain transverse through it. So you can see the cavernous ICA, which is transversing through a lake of cavernous veins. So near to the cavernous ICA, you can see the sixth nerve. So you have the third nerve, fourth nerve, fifth nerve, V1, which is transversing along the wall of the cavernous sinus, just medial to the temporal lobe. In fact, the sixth nerve is the only thing which is traversing through the inside of the cavernous sinus. So this is what we know from MBBS. The reason why I did not talk about V2 is this picture is actually incorrect, because according to the current concept and according to Roton, the V2 is not content of the cavernous sinus. It travels outside the cavernous sinus. So this is what we know already about cavernous sinus. Coming to some revision, this is a cut section of the skull. So as we know, this is the lesser wing of sphenoid. I'll just say it so that we'll be coming across these bony landmarks later throughout the presentation. So this is the lesser wing of sphenoid. It continues as the anterior clinoid process here. So medial to the anterior clinoid process, you have the optic canal here, through which the optic nerve comes. Between the optic nerve and the anterior clinoid process, here is the part where the ICA comes. So always remember the ICA, the supraclinoid ICA, enters into the subarachnoid space just medial to the anterior clinoid process here. And if you trace the ICA, it forms an impression on the lateral aspect of the body of sphenoid. So this area, in fact, you can see a sulcus here, and this sulcus is called the carotid sulcus. So the carotid courses medial to the anterior clinoid process, and it courses along the carotid sulcus, and proximally it enters into the cavernous sinus through the foramen lacerum. Okay, so we'll be coming across this later in the presentation. And here is the cella. The optic chiasm will be somewhere here. The tuberculum cella, dorsum cella, and this is the posterior clinoid process, the lateral aspect of the dorsum cella. So posterior clinoid process, anterior clinoid process, and this is the petrous bone. So petrous apex will come somewhere here. And just before the petrous apex, you can see a depression here on the medial aspect of the petrous bone, where I'm pointing the pointer. So this area is called a trigeminal impression, because the trigeminal nerve comes for the pons somewhere here, and it enters into the supratentorial compartment over the petrous bone and creates an impression on the petrous bone, which is called trigeminal impression. So the trigeminal nerve comes like this. The V1 goes into superior orbital fissure here, which is just lateral to the anterior clinoid process. Meckel's the trigeminal nerve V1. V2 goes into the foramen rotundum here. V3 goes into the foramen ovale here. So this is foramen ovale. And lateral foramen ovale, you have this foramen spinosum. So this is just a revision of what the things which you already know about the skull base. So for superior orbital fissure, optic canal, clinoid process, posterior clinoid process, trigeminal impression, petrous apex, foramen, superior orbital fissure V1, rotundum, ovale, and spinosum. So with this knowledge, we'll start the detailed surgical anatomy of the cavernous sinus. So whenever you see, imagine study a thing, you have to understand what are the walls of the, what are the approximate three-dimensional shape of the area which you are interested in. So cavernous sinus would look somewhat like this boat. So this is a peculiar boat that it is cut in the back. Okay, so it has a posterior wall, lateral wall, medial wall on the other side, and a roof. You have to notice that it doesn't have an anterior wall or a floor. So you have the medial wall, lateral wall, which converges together in the inferior aspect. So since it converges towards inferior aspect like a V, it doesn't have a floor as such, cavernous sinus. The cavernous sinus is a roof, which is seen here, and it is a posterior wall. So cavernous sinus has four walls: the roof, medial wall, lateral wall, and the posterior wall. The keel of the boat, which is seen here, which will correspond to superior orbital fissure in as far as cavernous sinus is concerned. So we'll discuss the boundaries of this area in soon. So cavernous sinus is an area which is anteriorly bound by the superior orbital fissure. Like I told, the tip of the boat will be in the superior orbital fissure, and posteriorly it becomes broad and occupies an area between the dorsum, lateral aspect of dorsum sellae, which is the dorsal posterior clinoid process, and the trigeminal impression. So if I draw a line connecting the two-dimensional line connecting the cavernous sinus boundary, so it would look somewhat like this. So this is the area of the cavernous sinus. It is like a T. So it is. This is a picture taken from Roton. You can see you connect to the superior orbital fissure, the posterior clinoid process, and the medial aspect of the trigeminal impression. Okay. The ideal definition is the medial aspect of Meckel's cave, but for the time being, we'll name it as trigeminal impression. So it is a triangular space which is bound like this. So the apex is in the superior orbital fissure, and as you see, the foramen ovale, which is noted here, is outside the cavernous sinus. So is the spinosum. So this is the rotundum, which becomes over here. And so these are the boundaries of the cavernous sinus. Superior orbital fissure. Posteriorly, it is a attachment from the posterior. It is a rod similar to the boat. So the roof. Is formed by dual folds. So you have petrous here. Forms three lines. So you can see the petrous apex here. So in the petrous apex, you draw a line to the anterior clinoid process. This line is called the anterior petroclinoid fold, which is otherwise we usually call it as the tentorial edge. From the posterior clinoid process, you have a line going into the tip of the clinoid process, which is called the interclinoid line, because the posterior connecting the posterior clinoid process and the anterior clinoid process. And connecting the petrous apex to the posterior clinoid process, you have another line, which is called the posterior clinoid fold. So it forms a triangular area which folds of dura, which is called the roof of the cavernous sinus. It is otherwise called the oculomotor triangle, because the center of the triangle, you have the third nerve entering into the cavernous sinus through its roof. So as far as roof is concerned, roof is formed by three dural folds, which are basically thickenings of the dura. So anterior petroclinoid fold, I think everyone would have seen at least once especially in temporal lobectomy, the tentorial edge, which we call, is actually the anterior petroclinoid fold. So that forms the lateral part of the roof of the cavernous sinus. And when you connect the posterior clinoid fold and the interclinoid fold, it forms a triangle, which is called the oculomotor triangle, because third nerve lies in the center of this triangle. So during Sylvian dissection, which we usually see in subarachnoid hemorrhage aneurysm surgeries, lateral to the IC, you have the PCOM, and lateral to it, you have the cranial nerve third, which enters and disappears into a dural fold. So that is this area. It is the roof of the cavernous sinus in the anterior aspect. So roof of the cavernous sinus is formed by these three folds and the oculomotor triangle. The clinoid process is seen in this picture. Coming to the posterior wall, as I told before, posterior wall is not a pointed structure. It's a broad structure. So it has a superior margin and inferior margin. So the superior posterior petroclinoid fold forms the superior aspect of the posterior part of the posterior wall. And area ligament wall as well as two cranial nerves enter into the supratentorial compartment posterior fossa through the posterior wall, which are the sixth nerve and the fifth nerve. So in this structure, the bottom image you can see superiorly you will have the posterior petroclinoid ligament somewhere over here, as seen in the pointer. Below the petroclinoid ligament, you have the cranial nerve 5, which enters into the supratentorial compartment along this area, along the trigeminal impression. And once you remove the dura over the cranial nerve 5, you'll see the superior petrosal sinus, which is coursing above the cranial nerve 5. And once you remove this also, medial and inferior to the fifth nerve, you have the petrosphenoid ligament, which connects the petrous apex to the sphenoid bone. So it forms a canal through which is called the Dorillos canal. So through the Dorillos, sixth nerve arises from the pontomedullary junction. It courses along the clivus, lateral clivus, and enters into the supratentorial compartment somewhere over here. So it is bounded by a ligament, dural ligament, which goes above it along the inferior aspect of the posterior wall. So that is that ligament, and together the canal forms a canal which is called a Dorillos canal. So the sixth nerve enters into the cavernous sinus through the Dorillos canal along the posterior wall of the cavernous sinus. So this is the inferior aspect of the posterior wall of the cavernous sinus, where sixth nerve enters and it remains lateral to the ICA. There's another picture of the AP view of the Gruber's ligament, and the sixth nerve coursing, entering into the supratentorial compartment through the Dorillos canal and coursing lateral to the ICA here. So posterior wall is related to two nerves, fifth nerve and sixth nerve. But one important thing you have to understand is the lateral wall. In fact, fifth nerve, like I told, it is not a part of the cavernous sinus. It lies just lateral to the cavernous sinus. So that lateral wall. The lateral wall of the cavernous sinus extends from the medial edge of the Meckel's cave posteriorly. So if I draw a line in this picture, the lateral wall will extend medial part of the cavernous sinus along the upper half of the Gasserian ganglion. So the trigeminal nerve enters from the posterior fossa into the supratentorial compartment through a cave, which is called the Meckel's cave, which will lie somewhere over here. So after the cave, it forms a ganglion, which is called the Gasserian ganglion. And this 1/3 of the Gasserian ganglion is situated inside the cavernous sinus. So the part of V1 is situated inside the cavernous sinus. So this part forms the lateral wall of the cavernous sinus. So the inferior half of the Gasserian ganglion as well as the V2 and the V3 is situated outside the cavernous sinus. So technically, when I say fifth nerve is related to the posterior wall of cavernous sinus, but it doesn't enter into the cavernous sinus. Only the part of the ophthalmic segment of the cavernous sinus, trigeminal nerve, enters into the cavernous sinus. So that finishes the lateral wall, and medial wall is along the lateral edge of the dorsum sellae, and the medial wall and lateral, like you remember the board picture which I showed you, joins together inferior to the carotid artery, and they meet together at the carotid sulcus, which I'll talk to you about soon. And one more important thing that you have to understand is, like I explained before, the maxillary nerve, the V2 or the V3, doesn't course inside the cavernous sinus. It in fact courses outside the cavernous sinus, unlike the picture which we remember from MBBS days. So this is another view of a cavernous sinus from the lateral wall. This is the middle cranial fossa where usually a temporal lobe sits. So this is the tentorial edge which we usually see at the end of your temporal lobectomies. This is the temporal polar region. So you have the tentorial edge, which is in fact the anterior petroclinoid fold, which is lateral part of the roof of the cavernous sinus. And you can see the posterior clinoid fold will come somewhere here, interclinoid fold, and third nerve entering the roof of the cavernous sinus. Posterior to the third nerve, you have the fourth nerve, which is entering into the cavernous sinus, which is related to the tentorial edge here. And you have the fifth nerve, which is entering into the entering along the lateral wall of the cavernous sinus here. Okay. So so you have the temporal base dura, which is sitting over the cavernous sinus in this picture. In the next picture, in the next picture, once the temporal dura is lifted off the wall of the cavernous sinus, you can see the cranial nerve 5 and the segments. You can see the V1, V2, V3, and the cranial nerve 5. Here, one thing you have to understand is the superior petrosal sinus is above the cranial nerve 5. And after the superior petrosal sinus, there we can see the Meckel's cave. So what is Meckel's cave? I'll talk about Meckel's cave later. But fifth nerve, when it enters into the supratentorial compartment, it takes with itself a subarachnoid sheath containing CSF along with it from the posterior fossa. So it forms a hole which almost reaches till the one half of the Gasserian ganglion. So this subarachnoid space, which of posterior fossa, which continues along the cranial nerve 5 into the supratentorial compartment, is what is called a Meckel's cave. So in this case, when you strip the dura of the temporal lobe, as in this picture, you strip it out, and you can see the fifth nerve branches. Here you don't get CSF, but if you enter into this area of the Meckel's cave, you will find CSF, and the CSF will be the CSF from the posterior fossa. Okay, so that is the concept of Meckel's cave. You can see the Gasserian ganglion bare here, and the venous spaces related to that. We'll come into the details soon and later. So in the right bottom picture, you can see the margins of the cavernous sinus. So the superior wall, like I told, extends from the superior wall, extends somewhere above the ICA along the. So anterior part of the roof of the cavernous sinus is in fact formed by the anterior clinoid process, as seen here. And the posterior part is formed by the dural folds, which forms the oculomotor triangle, or the one between the anterior posterior pteroclinoid folds and the interclinoid fold, this area. The posterior wall, like I told, is a broad area, the inferior part of which is formed by the petrosphenoid ligament or the Gruber's ligament, which forms the Dorillo's canal through which sixth nerve enters from the posterior fossa into the cavernous sinus. And the lateral, like I told, this is a lateral attachment of cavernous sinus. And lateral to the lateral attachment, we have the trigeminal impression. Like I told, fifth nerve is as related to the medial part of Meckel's cave is the lateral boundary of the cavernous sinus. So the trigeminal nerve will be here, and the V1 enters into the cavernous sinus along this area. So this explains the walls. So we have a roof which is formed by the dural folds, posterior wall superiorly formed by the posterior petroclinoid ligament, inferior formed by the petrosphenoid ligament, lateral wall which is related to the medial aspect of Meckel's cave, and medial wall which is related to the dorsum cell. Medial wall is not seen in this picture. So these are the walls and boundaries of the cavernous sinus. And like you, I hope you understood, the third nerve, fourth nerve enter into the cavernous sinus, as well as fifth nerve. Of the cavernous sinus. So I wanted to show this picture again, how this picture is inaccurate. So V2 is shown as a content of the cavernous sinus in this picture, which is incorrect according to the current concepts. So third nerve, fourth nerve, and V1 lies on the lateral wall of cavernous sinus, and sixth nerve lying inside the cavernous sinus related to the ICA. So we'll discuss each one of these nerves separately. So the first nerve, which is a important part of cavernous sinus, is the cranial nerve 3. So as you know, cranial nerve 3 arises in the interpeduncular fossa. It courses laterally in between the posterior cerebral artery and the superior cerebral artery, and lateral to the ICA. So during Sylvian dissection, like I told you, remember, lateral to ICA and PCOM, you'll find a cranial nerve 3. And after a certain while, it will just disappear into a dural fold. So that dural fold is actually this area, which is medial to the tentorial edge, which is shown in this picture. So like I told, this triangle is called what? It is related to the third nerve. Third nerve is situated in the center of the triangle. So this triangle is called the oculomotor triangle. Okay, so oculomotor triangle will be situated just medial to the tentorial edge along the roof of the cavernous sinus, and that is how cranial nerve 3 enters into the cavernous sinus. And conceptually, cavernous, as you can see, this entire area is cavernous sinus. So cranial nerve 3 is related to the superior roof and the anterior aspect of the cavernous sinus. So it will go somewhat like this and disappears beneath the anterior clinoid process into the superior orbital fissure. So that is how the cranial nerve 3 courses through the cavernous sinus. So he enters through the roof of the cavernous sinus, courses through the lateral wall of the cavernous sinus. Okay. So that is the neural relation of cranial nerve 3. So after cranial nerve 3, we have the cranial nerve 4. So cranial nerve 4 courses along the tentorial edge and enters posterolateral to the cavernous sinus somewhere here. So cranial nerve 3 would enter here, cranial nerve 4 would enter somewhere here, along into the cavernous sinus. And it also courses on the lateral wall of the cavernous sinus. And as you know, trochlear nerve initially will be lateral to the third nerve, as seen in this picture. Third nerve and fourth nerve will be, so third nerve above, fourth nerve below along the lateral wall. But as you know, trochlear nerve supplies superior oblique muscle. So superior oblique muscle is a muscle which is situated on the medial aspect of the orbit. So when does it cross the third nerve? So this crossing happens below the anterior clinoid process and somewhere near the superior orbital fissure. So initially, below the base of anterior clinoid, below the base of the anterior clinoid process, the fourth nerve will remain inferior and lateral to the third nerve. And as it courses through the superior orbital fissure, it passes medially between the optic nerve and the dura lining the anterior margin of the anterior clinoid to reach the medial part of the orbit, and that is how it supplies the superior oblique muscle. So during your cavernous sinus exposures, you usually don't find. So here you can see third nerve entering on the roof and lateral to the fourth nerve entering, and it is inferior to this. And here beneath the clinoid process and the anterior aspect, just before its entry into superior orbital fissure, fourth nerve courses from lateral aspect to the medial aspect of the third nerve. So that is how fourth nerve reaches the medial aspect inside the orbit. So that is the relations of the third nerve and fourth nerve as far as cavernous sinus is concerned. And coming to the next nerve of the cavernous sinus, which is this fifth V1 ophthalmic nerve. So like I told, the trigeminal nerve arises from the pons. It courses through the posterior fossa assistance and enters into a supratentorial compartment through a cave, which is called. As you can see in this picture, this picture is taken from Roton, but this cranial nerve 3 is wrong. It is actually cranial nerve 5. So you have the 7th-8 complex here, and cranial nerve 5, which is entering into the cave along the trigeminal impression here. So trigeminal impression is this area, which is covered by dura in this picture, this triangular area. So you can see a cave with a space around the nerve. So this space contains CSF. This is a subarachnoid space. It extends till the Gasserian ganglion. So this is the posterior fossa CSF. This is actually posterior fossa CSF space, which is extending into the supratentorial compartment. So this cave of subarachnoid space is called the Meckel's cave, and it is situated above the trigeminal impression and will form the lateral aspect of the wall of the cavernous sinus. So this Meckel's cave will be somewhere over here. So after the Meckel's cave, the Gasserian ganglion splits into V1, V2, V3. The V1 enters into the lateral wall of the cavernous sinus and courses superiorly and medially and enters into the superior orbital fissure at the keel of the cavernous sinus. So third nerve, fourth nerve, and V1, these lie on the lateral wall of the cavernous sinus. And like we know already, cranial nerve 6 enters through the Gruber's ligament and courses along the lateral aspect of ICA inside the cavernous sinus. So there is only one nerve which is inside the cavernous sinus, that is sixth nerve. And sixth nerve, one more important thing you have to understand about the next sixth nerve is sixth nerve will be seen at the level of V1. So sixth nerve is not seen in this picture because it is medial. It is hidden by the V1 ophthalmic segment in this picture. So it will be between the ICA and V1. So we want to search for sixth nerve in the cavernous sinus. You have to go medial to the fifth nerve, V1 of cavernous sinus. Like I told, the inferior aspect of Gasserian ganglion and the V2, V3 are situated outside the cavernous sinus. Although they are related to the cavernous sinus, it's outside the cavernous sinus. Okay. So, like I told, abducen nerve pierces, you can see the abducen nerve entering through the Gruber's ligament into the supratentorial compartment, and Meckel's cave, which is situated superolateral to it. This is again a revision. This is the petrosphenoid ligament or the Gruber's ligament, which forms a canal, which is called the Dorillos canal, through which sixth nerve enters into the cavernous sinus and courses lateral. And you can see here sixth nerve is seen because V1 is reflected out. So sixth nerve is situated at the level of V1. This is an important concept you have to understand. Okay. So lateral to the sixth nerve, you have the trigeminal impression. Okay. The previous image, the trigeminal nerve was kept intact. That is why we could not see the sixth nerve. So the trigeminal impression, medial aspect is the lateral wall of cavernous sinus. Just for revision, I am saying this. Okay. So Meckel's cave would form somewhere here. So I think that finishes the neural relations of cavernous sinus. Coming to the concept of cavernous sinus and the middle fossa triangles. So there are three cavernous sinus triangles which are important. The first triangle is clinoidal triangle. I'm sorry, this is incorrect. Sorry, cavernous sinus triangle. First cavernous sinus triangle is the clinoidal triangle. The second one is the oculomotor triangle. Third one is supratrochlear triangle. The fourth one is infratrochlear triangle. So first we'll discuss what is clinoidal triangle. So as the name indicates, it's a portion which is bounded by the clinoid process. And what we get after we remove the clinoid process. So this is your anterior clinoid process covered by dura. So once you remove this part, whatever triangle you see is the clinoidal triangle. So what are the contents of the clinoid triangle? The content is the clinoid process. So what you get after removing the clinoid process, what you see after removing the clinoid process is, medially you will find the optic nerve here. Like I told, here you will find the ICA in between the optic nerve and this thing. And infrolaterally you will find the, inferiorly you will find the cranial nerve 3. So this is the clinoidal process, anterior clinoid process area. And once you remove the clinoid process, what do you see? Medially on the superior aspect, you will find the optic nerve. On the medial, infromedial aspect, you will find the ICA, which is also called the clinoidal ICA. And inferiorly, you will find the cranial nerve 3, which is entering inferiorly into the this thing. So clinoidal triangle is this triangle is called clinoidal triangle. Show it once again. So the triangle which is bounded by the clinoid processes. So this is clinoidal triangle. So you have the optic nerve which is situated medial. Infromedially you have the ICA. So always remember, even if from sleep you are asked, clinoidal ICA is medial to the clinoid process. So this relation has to be remembered. Okay. So and the third nerve will be related to the inferior aspect. So 2 ICA, cranial nerve 2 ICA and third nerve related to the clinoidal triangle. And here you can see the anterior petroclinoid fold, which forms the tendorial edge, the interclinoid process, and the posterior clinoid fold. So these 3 forms another triangle, which is called the oculomotor triangle, like I explained before. So this is another part of the roof of the cavernous sinus. So these 2 triangles are related to the roof of the cavernous sinus, the clinoidal triangle and the oculomotor triangle. And how oculomotor triangle is important? Because your cranial nerve 3 is enter into the cavernous sinus through the center of the oculomotor triangle. So these are the initial 2 cavernous sinus triangle, the clinoidal triangle and the oculomotor triangle, which are related to the roof of the cavernous sinus. Clear? So coming to the oculomotor triangle, I told already. So oculomotor triangle is a triangle which forms the roof of the posterior facet of the roof of the cavernous sinus, and third nerve lies in the center. And this is the clinoidal triangle. And I told you to remember, ICA is related medially to the clinoidal triangle, and optic nerve will come here, and third nerve will course inferior to the clinoid process. Coming to the supraclinoid next triangle. So after third nerve, you have the trochlear nerve. So there are 2 triangles which are related to the trochlear nerve. One is supratrochlear. Let me turn on the laser pointer. So this is a supratrochlear triangle. This is the infratrochlear triangle, the triangle inferior to the 4th nerve. So here the third nerve entering the roof, entering into the superior orbital fissure. The 4th nerve coursing along the tendorial edge, entering into the cavernous sinus, entering into the superior orbital fissure. And you have the V1 entering into the cavernous sinus and going into superior orbital fissure. So this triangle, once again, this triangle formed between the third nerve, superior aspect of the 4th nerve, and the dural entry points of both. This small triangle is called the supratrochlear triangle because it's related above the trochlear nerve. As you see, it is a very small triangle, and you can have a glimpse of the cavernous ICA through this. And another important triangle inferior to the trochlear nerve is called the infratrochlear triangle. Since it's important, it is a named triangle. It is also called the Parkinson's triangle. Okay, the triangle between the 4th nerve, superior aspect of V1, and the line connecting the Meckel's cave entry and the entry point of 4th nerve into this. So this triangle, as you can see, is quite broad. I'll erase that to show you better. So this infratrochlear triangle in this area is a very important triangle because it is broader than the supratrochlear triangle, and it gives a good view of your cavernous ICA. So in many surgical approaches, how Parkinson described this triangle was the meningiohypophyseal triangle many times arises from this triangle, the infratrochlear triangle. So initially, before the era of endovascular interventions, this triangle was entered for treatment of carotid cavernous fistulas arising from this area. And another importance of this area is, as like I told, 6th nerve is related medial to the V1. So when you want to expose 6th nerve in certain cases, this is the area where you enter the infratrochlear triangle. Okay, so infratrochlear triangle situated between the 4th nerve and the V1. And coming, like I told, the other importance of the infratrochlear triangle is meningiohypophyseal trunk origin and the posterior bend of ICA. So the ICA, which when it enters into the cavernous sinus, it comes here, it bends here, and then again bends here to form the S-shaped loop. Okay. So these are the cavernous sinus triangles. The roof triangles are the clinoidal triangle and the oculomotor triangle, and the lateral wall triangles are the supratrochlear and the infratrochlear triangles, which are related to the 4th nerve, as explained before. Coming to middle fossa triangle. So this middle fossa triangles are situated lateral to the cavernous sinus triangles in this area. But as we know, the cavernous sinus margins are medial to the in this area. So the triangles in this area are outside the cavernous sinus. But since it is in close relation to the cavernous sinus and they're exposed in most of the cavernous sinus approaches, they are discussed in this section. So the middle fossa triangles. Yeah, the first middle fossa triangle is the andromedial middle fossa triangle. So it's quite simple, like four triangle, the anterior medial triangle. Between V2 and V3, we have the anterolateral triangle. Between V3 and something else, we have the Glasgow's triangle, and then we have the Cavazis triangle. So coming to the posterior lateral middle fossa triangle, first we'll talk the andromedial middle fossa triangle. So andromedial middle fossa triangle is between the V1 and the V2, and their entry points into the superior orbit fissure and the maxillary foramen rotundum. So this triangle is called the andromedial triangle. And this triangle between the V3, V2 and their entry points, that is foramen ovale and rotundum, is called the anterolateral triangle. The importance of these triangles are when you drill this bone in this area, you will enter directly into the sphenoid sinus. So importance comes usually in transplant approaches. Andromedial triangle, anterolateral triangle. Lateral to the V3, we have the posterolateral triangle here and the posteromedial triangle here. These triangles are important because when you drill this bone, you can enter from the supratendoral compartment into the posterior fossa. So that is the importance of these posterolateral and posteromedial triangles. So I'll come into the details. So you have the posterior fossa, posterolateral middle fossa triangle. Posterior lateral middle fossa triangle is also called Glasgow's triangle. It is formed by the posterior boundary of V3 and GSPN, greater superior petrosal nerve, rises here and it goes into geniculate ganglion somewhere here. Okay, so this triangle which is formed by the posterior aspect of V3 and it's the area where GS crosses the V3 and enters in a geniculate ganglion. So this triangle is called the Glasgow's triangle. The importance of Glasgow's triangle is that your middle meningeal artery, foramen spinosum, will be situated at the center of the Glasgow's triangle. So, in retrospect, when you do subtemporal approaches, how you identify the foramen spinosum is it will be situated 2 centimeter medial to the zygoma root. So, whenever you're operating EDS, there is a lot of bleed. You just trace the zygoma root, go 2 centimeter inferior to it, you will find the foramen spinosum and the middle meningeal artery. In fact, if the bleeding is controlled, you can just trace the V3 just medial to it, and GSPN will be just posterolateral to it, posteromedial to it. Okay, so this is Glasgow's triangle is the area where foramen spinosum is situated, or you can just trace the middle meningeal artery from the dura into the foramen spinosum here. So root of zygoma is the landmark for foramen spinosum. So in many scalable approaches, when you want to expose the Glasgow's triangle, you initially trace the middle meningeal artery into the foramen spinosum. Laterally, you will find the V3 and anteriorly you will find V3, posteriorly you will find GSP, and that is how you identify the Glasgow's triangle. So once Glasgow's triangle is identified, the importance of Glasgow's triangle is that foramen spinosum is in the center. But the more important triangle in this area is the Cavazis triangle, which is the posteromedial middle fossa triangle, which is this area. So it is formed by the between the greater superficial petrosal nerve and the lateral edge of trigeminal nerve between the Meckel's in the this and the entry geniculate ganglion and the so there is a safe area in the Cavazis. There's no important in the Cavazis triangle. Okay, and one more important is GSPN. So ICA just deep to it. So if you drill beneath the GSPN, you will enter into the Petrus ICA. And as you geniculate ganglion, so your internal acoustic meatus will be situated. So it will be located here. So internal acoustic meatus here, ICA here, and this area is safe to drill. So this area is called the Cavazis triangle. So when you drill through the Cavazis triangle, these approaches are called anterior. These are called anterior. We remove the petrous bone without damaging the ICA or the. That is how you identify this triangle. So you have the Cavazis triangle here, anterior to the GSP, and you have the Glasgow triangle where you have the middle meningeal artery. the anterolateral triangle, anteromedial triangle, the supratrochlear triangle, infratrochlear triangle, supratrochlear triangle, and the clinoidal and the oculomotor triangles. So these are the triangles of the in and around the cavernous sinus. Okay, so the important ones are the Parkinson's triangle here, the Glasgow's triangle here, and the Cavazis triangle here. Okay, which is separated by the GSPN. Okay, so coming to the neural relations, that brings us into the neural relations. We're running almost 10 minutes late, so I'll speed it up. So cavernous sinus arterial relations is quite easy because the only artery coursing in the cavernous sinus is the ICA. So you just have to understand how the ICA enters into the cavernous sinus. So you know the ICA, it courses along the petrous bone here. So this petrous bone has been removed to show this. And it courses medial to this petrolingual ligament to enter into the cavernous sinus from the foramen lacerum. As soon as it enters, it takes a bend. It's called the posterior bend of the ICA. So in this vertical segment, the sixth nerve arises and lies lateral to the ICA here. So ICA is intimately related to the sixth nerve through its course in the cavernous sinus. So at the posterior, after the posterior bend, it has a small horizontal course. After that, it curves again along the anterior clinoid process, anteromedial to the clinoid process. Okay, so this segment of ICA, which is inside the cavernous sinus, till it reaches the roof of the cavernous sinus, this S-shaped structure is what is called the cavernous ICA. It is completely inside the cavernous sinus. It is related to the sixth nerve throughout its course. Okay, you can see the third and fourth nerve related lateral to it. Okay, so that is the articulation of the ICA in the cavernous sinus. And one more thing is, once it reaches the roof of the cavernous sinus anteriorly, which is formed by the clinoid process, it will be bound by this triangular fold of dura, which covers the clinoid process. Okay, so this segment of ICA between this is called the clinoidal ICA, and here is the supraclinoidal ICA. So what you have to understand is this part of ICA is outside the dura. There is no subarachnoid space here. Okay, so this, when there is a bleed in the cavernous sinus, there will not be subarachnoid hemorrhage. It will be extradural hemorrhage. But patient can present with carotid cavernous fistula proptosis and not if there is a bleed here. Okay, and if there is clinoidal ICA, we'll come into the details of the carotid collar later. So this ICA is technically outside the subarachnoid space. Okay, it is basically something like interdural, and ICA enters into the subarachnoid space after the clinoid process here. Okay, we'll come into the details later, but this is the annotations of the cavernous ICA. Coming to the intracavernous branches, the ICA has three important intracavernous branches. Okay, the most important one is the meningohypophyseal trunk. It usually gives three branches. The first and important artery is the tentorial artery, also known as the artery of Bernasconi Casinari, which courses lateral and enter into the tentorium, like the name indicates. The second branch from meningohypophyseal trunk is the inferior hypophyseal artery, which goes into the posterior pituitary capsule. The third artery is a dorsal meningeal artery. The importance of and the other vessel which arises from the cavernous ICA is the inferolateral trunk, which is also known as the artery of the inferior cavernous sinus. The importance of cavernous ICA branches is that usually in angiograms, cavernous ICA branches are not seen. And it is said that if you see a cavernous ICA branch arising from the cavernous sinus, is usually pathological. And as you know, DSA used to be a very important diagnostic tool for lesions and other pathologies in the pre-CT and MRI era. So they should see any lesion arising from any artery arising from any arterial filling from the cavernous ICA and predict that there might be a lesion here. So visualization of the meningohypophyseal trunk or inferolateral trunk used to be considered as pathological. Okay, and one more thing which I have not added in this articulation is the persistent trigeminal artery will also be related to the cavernous ICA. Okay, so that's it with the articulations of the cavernous sinus. Coming to the cavernous sinus venous relationships. So as you know, cavernous sinus is connected to many supra and infratentorial veins. So it is connected to the orbit through the superior ophthalmic vein, the inferior ophthalmic, and the central retinal vein. It is connected to the dura through tributaries of the middle meningeal veins. It is connected to the transverse sinus through the superior petrosal sinus. It is connected to the jugular bulb through the inferior petrosal sinus. It is connected through various emissary veins into the pterygoid venous plexus, and through the facial veins through the ophthalmic vein, which courses through the orbit. Okay, and one more thing you have to understand is the basilar sinus, which is the last and most constant intercavernous, and cavernous sinus is in fact connected to each other, and it usually happens through the anterior and the posterior intercavernous sinus. There is another connection which lies along the posterior part of the clivus, which is called the basilar sinus, and it is the most constant intercavernous connection existing between the cavernous sinuses. So this is the area of the cavernous sinus. All these blue areas you can see in and around the cavernous sinus. These are the veins which are related to the cavernous sinus. And in fact, as you see, superior petrosinus is here. These are the veins around, emissary veins around the. These veins are in fact not inside the cavernous sinus. They enter into the cavernous sinus somewhere here. Ophthalmic veins coming here, ophthalmic vein and ophthalmic and retinal veins coming here. So this is how cavernous sinus is connected to most of the veins in the skull. Coming to the osseous relations of the cavernous sinus. So cavernous sinus, like I told from the first picture, like we discussed, petrous apex, you draw a line connecting the petrous apex, posterior clinoid and the superior orbital fissure. Cavernous sinus is situated between these, in this triangle. Cavernous sinus, from our MBBS knowledge, we know that it is situated on the lateral aspect. This is the body of sphenoid. So it is situated on the lateral aspect of the body of sphenoid. And usually on the body of sphenoid, you find the impression on the floor of the body of sphenoid, which is called the carotid sulcus. And like I told, I told, if you remember, the medial and the lateral walls of cavernous sinus join together over the inferior to the carotid sulcus here. So this carotid sulcus is situated over the floor of the cavernous sinus. And the roof of the cavernous sinus, you have the anterior clinoid process. Anterior part of the roof of the cavernous sinus, you have the anterior clinoid process. So, and one more osseous relation which you understand is the foramen ovale and spinosum are situated lateral to the cavernous sinus. Okay. Coming to anterior clinoid process and optic strut. So anterior clinoid process is a very important bone which is related to the lesser wing of sphenoid and the cavernous sinus. So this is the lesser wing of sphenoid which we expose more in most of our craniotomies. So as you extend medially, it will end, the sphenoid wing will be somewhat like the lesser wing of sphenoid as you trace, it will end in a triangular piece of bone which is called the anterior clinoid process. So anterior clinoid is a pyramidal like a triangular piece of bone with a tip, a base, an anterior root and a posterior root. So I'll repeat again. So it's a triangular pyramidal kind of bone which extends as a medial part of the lesser wing of sphenoid. So the lesser wing of sphenoid would come somewhere like this. This side it will come somewhere like this. So it is situated at the tip of the lesser wing of sphenoid. It is like a pyramid. It has three roots. One is the base of the clinoid process which is related to the lesser wing. Here this is the base of the clinoid process which is lesser wing. And after the base of the clinoid process, you have the tip, then one root which is situated anteriorly. This is called the anterior root of the cavernous anterior clinoid process, and this root is called the posterior root of the clinoid process. This anterior root of the clinoid process, as you can see, goes over this canal and forms the roof of this canal. This canal is called the optic canal. So the roof of the optic nerve is formed by the anterior root of the clinoid process. Okay. And posterior root of clinoid process separates forms the floor and lateral wall of the optic canal. So this posterior root also separates the optic canal from this canal, which is called the superior orbital fissure. Okay. So this posterior root of clinoid process is also called optic strut. Okay. So optic strut is that part of bone which is also called as the posterior root of the clinoid process. So optic strut is equivalent to the posterior root of clinoid process. And optic strut is a structure, bar of bone, which is also the posterior root of clinoid process, which separates the optic canal from the superior orbital fissure here. Understood? So that is the importance of optic strut. And one more very important point about the optic strut is this is the carotid sulcus. The carotid artery comes here. It curves over the optic strut. So it is on the anterior surface of the clinoidal ICA. Okay. So it curves over here and enters superiorly into the supratentorial, supraclinoid compartment. So this is the importance of optic strut. So I'll repeat again. This is the lesser wing of sphenoid. It comes into the base of the anterior clinoid process. Anterior root, which forms the roof of the optic canal. The posterior root, which forms the floor of the optic canal. And it separates the optic canal from the superior orbital fissure. Okay. And it is related to the ICA here. Okay. I think I'll, to see the relation of clinoid process, I'll show another photo. So I'll show that photo later. So these are the relations of the clinoid process. So another important concept about the optic strut is this optic strut, when you come from in transnasal approaches, there's an area which is called the lateral opticocarotid recess, LOCR. Okay, so you have the carotid prominence here, the optic prominence here, and in between you have a recess. Many of you would have seen this. This is the optic nerve, which forms an impression called the optic protuberance. The carotid, which forms a protuberance here, and in between optic nerve and carotid, you have a depression here. So when you have a depression, you have a projection inside. So when you're looking from the nose, there's a depression here. So when you're looking from the intracranial cavity, you will know a projection. You will see a projection here. So the lateral OCR forms the intranasal landmark for the optic strut. So this is the optic strut. Okay, which separates the optic canal from the superior orbital fissure. Will be somewhere here. Okay, so LOCR is a landmark for your optic strut in intranasal approaches. Okay, so the opticocarotid, that is the importance of opticocarotid recess. Okay, so this and how clinoid is related to the cavernous sinus is that clinoid forms the roof of the cavernous sinus. Anterior part of the roof of the cavernous sinus is formed by the clinoid process, and the third nerve enters inferior to the optic strut. Okay, so understanding the anatomy of anterior clinoid process is very important, and it is always discussed in parallel with the cavernous sinus anatomy. Okay, so I hope you understood this, and we'll go into the last topic of the day, which is the anatomy of the carotid collar. So carotid collar, like I told, is just a dural fold through which clinoidal ICA transverses. So you can see this is a cavernous ICA. Okay, once it reaches the area of the clinoid process, which is here in this picture, in the same picture here, the dura of the mid-temporal fossa, when it reaches the anterior clinoid process, it splits into two to enclose the anterior clinoid process. One dural fold is created at the roof of the cavernous sinus. This is called the proximal dural ring. Another dural fold is created at the entry point into the subarachnoid space, which is called the distal dural ring. So the part of the ICA between the distal dural ring and the proximal dural ring is called the clinoidal ICA. And this collar of dura is called the carotid collar. So carotid collar is technically a channel or a collar created by dural folds through which the clinoidal ICA courses. Okay, and it is situated medial to the clinoid process. So as you can see, this is the temporal dura which is coming to the clinoid process. So the temporal dura will come to the clinoid process. It will split into two. One goes above, one goes below. Okay, so the one which goes above will form a dural fold along the roof of the optic nerve, which is called the falciform ligament. But anteriorly, the same dural fold will form a ring around the carotid. So this ring is called the distal dural ring. Okay, so the dura which gets reflected on top of so the temporal dura will come like this. It will get reflected on top, and it forms the falciform ligament here. So falciform ligament here, and anteriorly it forms the carotid collar here. Okay, so this is formed by the dura propria, which is going over the clinoid process. And when the dura splits here, another dura, a fold, goes like this and forms a ring around the ICA. So this ring is called the distal dural ring. So this is the proximal dural ring. This is the distal dural ring. So, and after this ring, this dura continues posteriorly to form the medial wall of the cavernous sinus. Okay, so the part of ICA situated between these two are called the clinoidal carotid, and is also this area of dural folds is called the carotid collar. So, like I told before, the carotid artery lies in the clinoid process. As it will somewhere. This is where carotid artery lies. Process. The dura separate. So, like I told, the dura of temporal lobe, when it reaches the ACP, it splits into two and forms three dural folds. So, first one is the falciform ligament, which covers the optic nerve superiorly, the proximal dural ring, and the distal dural ring. So, coming to the proximal dural ring, like I told, it forms this proximal dural ring is situated on the inferior aspect of the clinoid process. So, the inferior aspect of the clinoid process is same as the roof of the cavernous sinus. So, proximal dural ring technically is what we saw in our diagrams as the carotid oculomotor triangle. So the proximal dural ring is another part of forms the roof of the cavernous sinus, is also called carotid oculomotor membrane, because and it separates the anterior clinoid process from the third cranial nerve. The ring is incomplete on the medial side of ICA. So separation is easy from that area. And the deep layer of temporal fossa continues as proximal ring and forms the medial cavernous sinus wall. Coming to the distal dural ring, the distal dural ring, like I told, the other fold of dura, it goes over the clinoid process to form the falciform ligament here. Then another dural fold goes and covers the ICA distally. So this forms the distal dural ring. So this part between the distal dural ring and the proximal dural ring is what is called the clinoidal ICA, which is seen after removal of the clinoidal process in the clinoidal triangle. Okay. So here you can see this is the distal dural ring. Another part of distal dural ring going above the optic nerve as the falciform ligament here. Okay. So falciform ligament, distal dural ring, the clinoid process was sitting here. Okay. An inferior dural fold, you see, it is going around the ICA here. So this is the proximal dural ring. And beneath the proximal dural ring, you have the cranial nerve 3. So when you do clinoidectomy, you approach, this is the sphenoid wing. So you come here, you keep drilling here. Then you you remove the roof of the optic nerve. And once you remove the clinoid process, this is what you get. So while you're doing clinoidectomy, your optic nerve will be situated superomedially. ICA will be situated inframedially. And you have the third nerve, which is situated inferiorly. So the third nerve is protected from the clinoidectomy by your carotid oculomotor membrane, which is also called the distal dural ring, which also forms the distal dural ring when it goes medially. So this fold of dura goes medially and rotates around the ICA to form the distal dural ring. Carotid oculomotor membrane, distal dural ring. This is the proximal dural ring, and this is the falciform ligament. So this fold of dura through which carotid artery course, this is some 4 to 5 millimeter course of fold of dura through which carotid artery courses. This area of dural folds are called the carotid collar. So this another concept when you read about carotid collar is what is called the carotid cave concept. So this was introduced by Mr. Kobayashi. So in the medial aspect of, so this is the proximal dural ring. This is the distal dural ring. The area between the two dural rings are called the carotid collar. Okay, so this is the cavernous ICA. This is the supraclinoid ICA. So as you know, the part which is in the cavernous ICA and the clinoid ICA traditionally are considered to be extra-arachnoid. So when there is an aneurysm here in this area, in the carotid collar or the cavernous ICA, it usually will not got subarachnoid hemorrhage because the bleed will happen outside the subarachnoid space. But there is an area in the medial aspect of the carotid collar where the subarachnoid space of the supratental compartment extends into the carotid collar. So this small area is called carotid cave. So this concept was introduced by Mr. Kobayashi. So this is an anatomy dissection video which I have taken from the internet. So as you can see, this is the proximal dural ring should come somewhere over here. But medially, this proximal dural ring, there is a gap through which the subarachnoid space from the supratentorial compartment enters into the carotid collar. So if there is an aneurysm here in this carotid cave, it can bleed and cause subarachnoid hemorrhage. Understood? So this is the concept of carotid cave. This Kobayashi also is the famous neurosurgery for another thing. He is the one who discovered the subperiosteal dissection technique for reflecting the temporalis muscle. Okay. Another pop culture reference is Kobayashi is the name of the advocate in a famous Hollywood movie, Usual Suspects, if anyone has watched. Okay. So that is the concept of carotid cave. Okay. So I hope you understood the concepts of cavernous sinus anatomy today. But an important thing I'll tell you is there is a very important surgical approach called the Dolenz approach. So it was beyond the scope of this topic today. But as you can see, this is a lateral view. This is that middle cranial fossa, temporal lobe. So this is what you get to see after the temporal lobectomy. So when you strip the temporal dura from the cavernous sinus, it forms, and when you enter into the cavernous sinus, it forms a very beautiful pathway through which you can go into the skull base. So it forms a completely extradural approach into the skull base. So these approaches are called transcavernous approaches. So routinely, the transcavernous approaches are used for in trigeminal schwannoma routinely, but it can be used for other skull base tumors, basilar top aneurysm clippings, and other things. So Dolenz introduced this, and it is propagated by Ali Krishnan. So these videos are available in the internet. So if you watch these videos after this, after attending this seminar, I think you'll be able to have a better idea of how these skull base approaches are being implemented. So that's it. Thank you.